We have about 2 minutes left, I think, before we have to wrap this up, and I don't see anybody standing by that microphone. Uh-oh. Well, I'm sorry. Yes, jump right up there, please.
I'm Sue Darcy from the Gray Sheet. I'm just wondering if in Great Britain, 82% of the devices are approved by NICE, but then, Tomas, you're saying that the prices are too low of them, or they can't get what they, does that mean that everybody who sells a device in Great Britain is either losing money or not making enough to go out and then innovate? What is the argument you're making there?
No, the issue is that if you set a cost-effectiveness threshold, the incentive for manufacturers is to come in around that threshold to maximize the profits they can get in that country. So the implication of that is it doesn't have to be that you lose money, and it will most likely not affect innovation if it's UK only, because it's the smallest share of the overall world market. But the problem is that the implication of that is that when the reimbursement authority is asked to pick among more cost-effective versus less cost-effective technologies, everything is going to look equally cost-effective. Even though the resource cost involved, which is what we really care about, how much resources does it take, as opposed to the markup above costs, does it take to produce this treatment? What we're really interested in maximizing is health benefits given the resources involved to produce the treatment. We don't want to maximize basically with the markup above cost, which is essentially just there because of the reimbursement system. So the cost effectiveness analysis done by the reimbursement system, the fact that it reimburses based on cost effectiveness, determines the cost effectiveness levels they seek.
But actually, sorry, just to add that, if you actually look at the distribution of the outcomes of NICE evaluation over 10 years, we've got a slide that shows this, it's an S-shaped curve in terms of the distribution of cost per quality adjusted life year. So they're not all bunched around the threshold. There is a distribution. It's true there is a bit of a bunching, and it would be amazing if as a group of industries, the life sciences industry say, well, actually, now we know how that judgment about value for money is made by NICE, we're going to forget it and simply just price this product on whatever other basis we've got. How do companies price products? Well, you price it on the basis of what the market will bear. That's what you do. That's what all companies do. And there's nothing wrong with that. Healthcare systems have to make a judgment about whether or not what's offered to them is affordable. That's primarily a judgment about whether or not a product represents value for money. And those two things to come together, you get a set of behaviours which in part has the effect that Thomas is suggesting, but it isn't quite what he's suggesting. There is a distribution. There are products which fall well below the threshold that NICE has set, which is fine, it's great news. There are also some products which fall broadly above the point of inflection in our range of threshold, which are worth having, even though they're relatively much more expensive than some other products. In other words, they're less good value for money, but they're important for the healthcare system. There are some that fall way above it, and those are the products where, as much as they might bring some benefits for some patients, the cost is just too much for the health system, given that it's got a fixed amount of money and has to spread it as equitably as possible.
But NICE will approve an expensive product.
We might well do. Gleevec, imatinib for chronic myeloid leukemia, somewhere up close to £50,000 per quality adjusted life year, way above the centre point of the threshold range that we've got, was thought to be the right choice for the NHS, and it's turned out to be the case. And it was
we have time for one very last quick question, sir.
I'll do my best to make it fast. Can you hear me? There we go. I just wanted to support Dr. Deborah Davis-Ashim's discussion about when is comparative effectiveness research appropriate, because in the life cycle of products, the very early stage of development is typically focused on this question of safety and efficacy, right? So we're trying to prove that in very tightly controlled clinical trials so that we can demonstrate effectiveness. And we may do cost effectiveness studies with this if it's appropriate. But we're not asking the broader question about clinical applicability at that point, which I think comes much later. And of course, it's always a challenge for us in the US dealing with CMS versus FDA. FDA is asking for the safety and effectiveness, and CMS is asking for the clinical relevance of the product, which is much more difficult and will come later. Because we incrementalize these products and we make them much better over time, and we learn which patients benefit over a broader range of studies, then it seems much more appropriate to study them later after they've matured. We would have killed many, many new devices if we had studied them in the first few years of their introduction.
Okay, we will take that as a comment, and thank you very much indeed. Please thank our panel for their good efforts this afternoon. And thank you all very much for coming. I hope that you'll stay around for the next session that begins in 15 minutes, I believe.